Good morning, I am Rafael Ruiz Salmerón, Servicio Endovascular, Hospital Virgen Macarena, Seville, Spain. This is a Watchman procedure in a patient with complex transeptal puncture due to right phrenic paralysis. As you can see in the bicaval view, this is an compression of the liver against the right atrium. In this view, we start our transeptal puncture maneuver as well as we do that into the AP view. Our needle and cook sheath is now at the left brachiocephalic trunk, and we will remove it along the superior vena cava. It is very important to mark where the aortic root is with a pigtail. As you can see, during this removal we have to see two jump-in movements. This first that announces that we have left superior vena cava and we are inside the right atrium, and this second and definitive jump-in movement that announces that we have engaged the fossa ovalis. This engagement should be proven in echo. In the short axis view, we see the aortic valve as an anterior reference, and our tenting signal, that is how we are leaning against the fossa, pointing at the lateral left atrium wall. Once we are sure about our position, we have to cross to puncture the septum as we are doing right now. Now you can see the tip of the needle inside the left atrium. It is very important to perform now an angiography only to draw the left atrium silhouette. Now we over the needle advance the plastic, the dilator and the sheath, and after that over the dilator we will advance the sheath. All this maneuver of advancing the catheter into the left atrium should be performed in LAO projection. Now, once the sheath is into the left atrium, we will engage the left appendage. With a pigtail, we will perform some angiographies and to measure the left appendage ostium. And after we have selected our Watchman device, we will introduce the Watchman sheath. It is important to see this crossing of the septum with the Watchman sheath with an echo, only to differentiate a right crossing than a permanent tenting. Now with the pigtail we advance the Watchman sheath along the appendage to get the depth that we will need to deploy our device. In this particular case, we selected a 24 Watchman device. So the depth that we will need would be that is between the two distal marks. Now we are advancing the Watchman device until both distal markers are aligned, and then this maneuver of unsheathing that would be very controlled, very slowly, and always pointing the watchman sheath into an anterior position to be aligned with the long axis of the appendage. We are unsheathing slowly. Now this is the last part of the device, and we will perform some maneuvers to see if the implantation is right. The first, and it's very useful, is to inject contrast while we are performing the tag test. We are now very sure that the device is stable, and the other maneuvers should be to assess the position, assess the size, measuring the compression, and to assess if there is some presence or not of a leak. In this case, there were no leak, the compression was good, the position was good, and we saw the stability was good enough. So we will consider to finish our procedure. Thank you very much from Spain.